treatment is helping you or not. We're going to talk a little bit now about restrictive lung diseases. Restrictive lung diseases impair the movement of the lungs. They're compressed. It can because things like obesity. If you have a lot of weight pressing down on your chest, it can compress them. Lung fibrosis, and neuromuscular diseases and paralysis. You also see restrictive lung diseases in diseases like sarcoidosis, connective tissue diseases, and those are things like lupus. You see it in rheumatoid arthritis can affect your lungs as well. Scleroderma, which is a process where essentially you turn to stone. That's how most people describe that. Asbestosis, exposure to asbestos, and silicosis, which are sand particles that you see in sandblasters. Asbestos you see a lot in people who are pipe fitters, especially people who worked in like the shipbuilding industry. And there are drugs that can cause restrictive lung diseases as well. Some of the blood pressure medicines, some drugs that are used to treat irregular heartbeats can cause restrictive lung diseases. Lots of times if you're on one of these medicines and they take you off the medicine, you get better. That depends upon how long you've been on the medicine, how much damage it's done. And chemotherapy drugs can cause restrictive lung disease. It can also be caused by neuromuscular diseases, and these are people that don't actually have damage to the lung tissue, but the muscles that help them to breathe aren't working very well. Muscular dystrophy, multiple sclerosis, Lou Gehrig's disease, and myasthenia gravis. And diseases that actually affect the shape of your thoracic cavity, scoliosis, kyphoid scoliosis, and obesity. The total volume of air that you get out of the lungs is less than 80%. The lungs are smaller than you would predict them to be. You get the air out quickly, but you just don't have much air to blow out. And this is a patient with restrictive lung disease, and this is a 66-year-old black man with interstitial lung disease as a result of having a connective tissue disorder. You can see that the total amount of air he blows out is only 42% of what was expected from him. It's smaller than it should be. Because that's small, the amount of air he can get out is going to be small also. So that's why it's important to look at this ratio. He actually gets out 90% of all of that air that very first second he blows. He gets it out very, very quickly. He simply doesn't have much air to blow. When you look at the lung volumes, everything is small. The residual volume is going to be small. The total lung capacity is going to be small. You see all of these numbers over here are small. That's restrictive lung disease. Everything's smaller than it should be. On his diffusion, and this patient is on oxygen and has been for quite a while, his diffusion capacity should be at 30, and it's only at 3, only 12% of what it should be. And this is what his pictures look like. He has the normal shape he should have. It's just smaller than it should be. And when you look at the lung volumes graphically, you see the same thing. This is what his residual volume should be, but you can see everything is small. And that's restrictive lung disease. You got speed, but you just don't have any volume. Pulmonary function tests, kind of to summarize, they're going to help the doctor to diagnose your disease, whether you are restrictive or obstructive. They're going to help him to decide whether the treatment you're on is working or not, whether he needs to make some changes there. how the disease progresses, and it's just a piece of the puzzle, again, that the doctor uses to help determine what shape your lungs are in and what's causing your respiratory problems. And that's all I have. Does anybody have any questions? That's a lot of information. I tried to keep it kind of as basic as I could. Yes, sir?
This diffusion number, the little devices that you measure or put on your finger or whatever, in percentage, is that the diffusion?
No, that is not. That little thing, and it's a wonderful tool. It measures the percentage of your hemoglobin that's actually saturated with oxygen. The oxygen has to have the hemoglobin or the iron in our blood to travel throughout the lungs. And by putting that little clip on there, it gives you a pretty good idea what the oxygen level is in the blood without actually taking a blood sample and measuring it. Speaking of blood gases, most of you, especially those of you on oxygen, that is another lung test. And we do a lot of exercise testing as well. We do blood gases at rest, blood gases with exercise. There are a lot of different types of pulmonary functions. This is just the basic. You come in and you sit in the machine and spend about 45 minutes with us, and we give the doctor a lot of detailed information. But there are many other tests we can do as well.
When you were talking about the people with obstructive lung disease, the amount of air that stays in their lungs, does that have an effect on the oxygen level that goes in their blood?
Well, as the emphysema gets worse and that stale air is there, people with emphysema, yes, their oxygen levels do drop.
And what kind of effect would it have on you as far as the individual? Would it,
well, people with emphysema typically are short of breath when they try to do something. And many of them in the later stages are short of breath just sitting and resting. Yeah. Yeah, as that emphysema, that damage, that irreversible damage that's actually done to the lung tissue gets worse, usually the lower your oxygen level gets.
Are you saying that the amount that's left over in the lung stays in there so new air can't get in?
Well, it kind of mixes, you know, but it never really complete. Yeah, it never really complete. You always have some of that, what we call stale air left in there.
The residual, yeah.
Yeah. And it's not good to have a lot of that left in there. Ms. Abbott?
Weren't they doing some surgery to remove parts of the lungs?
That's correct, yes. And people that had big areas of dead space, yes, they did. I don't know how much we do that anymore. It's called lung reduction. But some people do benefit from there where they take out these large pockets of trapped air. Yes, sir?
You were speaking of the muscle in your chest. When you get short of breath, does that affect around, you know, I have it, it's like a tingling or not real, anything real severe, but it's something you know is there, and it goes down down in the upper part of the stomach. Is that the muscle?
Most of these people with muscle disease, like multiple sclerosis and muscular dystrophy, their muscles just get weak. They don't typically describe any kind of pain or anything associated with that. But the diaphragm, which is this big muscle that separates our abdomen from our chest, and it moves when we breathe in and breathe out, becomes paralyzed over time with these diseases. And so they have trouble getting the air in and out of their lungs. Like I said, in those types of diseases, not that they have lung tissue damage itself, and most of us are not even aware that these muscles are helping us to breathe. It just happens automatically until you're one of these unfortunate people that have these devastating illnesses that cause paralysis. Most of those patients will die as a result of pneumonia because eventually the muscles get so weak they have difficulty coughing. They have difficulty swallowing. It's another group of unfortunate diseases affecting the lungs. Yes, sir.
Is there there's always the opportunity of fluctuations within your numbers, right?
That's true.
So you have to maintain like a certain hour of the day that you go and the same respiratory nurse? Or?
Ideally, that would be, but in the real world, that usually doesn't happen.
I try to do that.
I'm actually a biological for work. You know, we have these machines, but we got to make sure the machines work. So once a week, and we have 3 of these big boxes, I have to do all of these tests on each one of those 3 machines, and I should essentially get the same number each time I do it. I do try to do that at the same time. I do better in the morning after I've had my lunch. I don't do as well.
Because I'm online very frequently, and sometimes on Facebook you have people that are like totally devastated by their numbers, and then you say that like, you know, it can happen, right? And then 3 months after that or 4 months after that, they come back and say like, hey, my numbers were up again, because they just had a bad time.
It's not a major up.
No. And
that's right.
It can affect it by
and even a little bit down is not a major down either. And I will tell you, most of the pulmonary doctors will tell you it's important to have an idea where your pulmonary function tests are. But don't get so wrapped up in the numbers that every time you see a little decline, you think, oh, gee, this is it. Well, you know, it could be just be that, you know, you have your asthma's kicking up that day a little bit, or you're just generally not feeling that good. Yes, ma'am.
Is there a rule of thumb as to how often one should have, if you have, say, emphysema, how often you should have a pulmonary function test?
I think most pulmonary doctors would tell you if you have a stable lung disease, probably once a year. Now, if your lung disease is not stable and you know you're continuing to deteriorate, you may have pulmonary functions more often. But it's not a test that you do every week. You know, if it's because you're on steroids and they need to follow that initially until they get you stabilized, you might do it maybe every 3 months for a while, and then it'll go to 6 months, and then maybe to once a year. But it's not
6 years. Is that?
6 years?
Yeah.
If you have lung disease, that might be a little long. It depends upon how stable you are. Yeah. Most people with active lung disease have it more frequently than that.
Thank you.
Well, thank you for having me here today. It's been my pleasure. And so good to see you.